Hello everyone and welcome to Moments in Medicine Live. As you know, we normally do these live chats every Wednesday at noon, but today we encountered a little bit of a technical difficulty. I will not make the cameraman point the camera back on himself, but I owe him one. This was a hard one to set up, so forgive us. We've got a great topic today. March, in case you didn't know, is Colorectal Cancer Month, so this is our topic today. And as we begin every chat, we just want to remind our viewers that the information contained today is to be used for just that, informational purposes only. So if you have questions about your immediate care or treatment plan, please direct those to your doctor. Today I am joined by two doctors, Nebraska Medicine colon and rectal surgeon, Dr. Sean Langenfeld, and surgical oncologist, along with liver, biliary, and pancreas surgeon, Dr. Brad Reames.
Hi.
That's the worst I'm going to get, is always giving you guys titles. It's hard to get through those. Thank you both for joining us today. And then please remember at home that while you are watching this live chat, you can always ask your questions. I'm going to have my phone on me, so I'll try to keep track of those in the comments section. So, getting started, Dr. Langenfeld, how many people in the U.S. are diagnosed with colorectal cancer?
Well, it's very common. About 5 to 6% of people in the United States are going to get colon cancer at some point in their lifetime. So it's the third most common cancer in the United States. It's also the third leading cause of death. And so a lot of people are going to have family members affected or know somebody that's had colorectal cancer.
Now, you can't use, for my purposes, colon and colorectal synonymously. There is some difference. Can you help explain that?
Yes, there is a difference between colon cancer and rectal cancer. They are kind of combined often when we discuss it because the way that they form and the way they're treated are similar. Rectal cancer means it's closer to the bottom of this long tube that is your colon, and the treatment's a little bit more involved with rectal cancer. It has a bigger impact on quality of life as well, but they're both very treatable and very curable.
Great. All right, Dr. Reames, colorectal falls within the gastrointestinal, or abbreviated GI, tract of cancers. What types of GI cancers affect the digestive system? Can you list a few of those?
Yeah, so you can potentially get a cancer from every different type of the gastrointestinal system. So here at Nebraska Medicine, we treat all of them. The gastrointestinal system specifically, the esophagus, the stomach, the gallbladder, the biliary tree, and then the liver and the pancreas, the small intestine, the large intestine, the rectum, and the anus are the primary areas where you could get cancers that Dr. Langenfeld and I treat.
Okay, and keep in mind those are all described as GI, so if you hear your doctor mention that. Okay, back to you. Who is recommended to get a colonoscopy, Dr. Langenfeld, and why is that screening so important?
It's important because colon cancer is preventable. The screening recommendations have recently changed to become more aggressive. We used to start everyone at the age of 50 for colonoscopy, and now if you're an average risk person that doesn't have a family history and doesn't have any symptoms, you're still going to start your screening at the age of 45. And it's usually about every 10 years after that if you don't have any findings on colonoscopy. If you do have polyps that are discovered, or if you have a family history of polyps or cancer, then the treatment is a little more frequent than that. There's a lot of different ways to screen somebody for colon cancer, including office-based tests, stool-based tests. The most effective and sensitive way to screen is with colonoscopy, and that is something we have to do a bowel prep the day before, which is the worst part for most people. The procedure itself nobody really remembers because you get very good sedation from an anesthesiologist. We look along the entire colon, and that can detect colon cancer, but in addition it can also detect precancerous lesions, polyps, and other abnormalities of the colon, and they can treat it and remove it before it has a chance to turn into cancer. So that's our single best tool for preventing colon cancer.
I think people get a little leery of the experience of going through the test. I know I had similar discussions with some of the mammogram techs on the ladies' side about, it sounds scary, but in your experience, everybody gets through it. It's relatively quick and non-invasive after they get through the test, a recovery.
Yeah, so most people feel normal later that day, and by the following day they're back to their normal self. Additionally, the old preps that we used to give people that were relatively gross tasting and high volume have changed. Now they have to drink less volume of liquid, and it's usually Gatorade mixed with a laxative, so it's not quite as gross.
Okay.
And so it sounds a lot worse than it truly is.
All right, Dr. Reames, I know we talked about this briefly, but what causes colon cancer? Is there a cause? Are there several?
So colon cancer can be caused by multiple different things. The primary cause would be a growth, as Dr. Langenfeld mentioned, from a precancerous lesion that is many different types of polyps that we're screening for on colonoscopy. And then over time, either if there are hereditary genetic changes or there are just environmental changes that happen as we all age, certain cells develop the ability to grow uncontrolled within the body, and then those cells grow and multiply, and eventually they become a small lesion, which becomes a larger lesion, which becomes a cancer. And that takes time. Different cancers, it takes a different amount of time. And so that's why it's really important for colon cancer to get your screening, because that colonoscopy potentially allows us to identify and remove those lesions long before they've grown large enough to cause a cancer or to move to another part of the body.
All right, so you need to make the time for the screening. That's number one. So let's say you're beyond that point and you unfortunately get diagnosed with colorectal cancer, and you are told by your doctor that the next step is surgery. Walk me through the different types of possible surgery depending upon the person's treatment plan.
So when somebody has colon cancer and there's no evidence of spread to other organs, then the way that we treat it is we remove it surgically. To do that, in the old days, typically required a very large incision and a long recovery time and pain, and sometimes it required a colostomy bag we poop into a bag. And in 2019, all of those are much less common. The vast majority of our surgery is done laparoscopically, meaning there's just small cuts and long instruments to remove the cancer. We also employ robotic surgery, where we use a robot to help us with the laparoscopy. And the benefit of that is that there's less pain, there's a faster recovery time, and truthfully, the outcomes are better with that, both short-term and long-term. There are some cancers that are early enough where we can actually remove from the inside and not have to remove the organ and not have to do a big surgery. And that's usually a combined effort with myself and the gastroenterologist. One version of that is something called TAMIS, which is essentially laparoscopy through somebody's anus. We're one of the few places that does that here in the Midwest, and that has been shown to be an even faster recovery time because there's no major surgery or resection involved.
And I'm going to have you repeat that one more time just for people to know. TAMIS, T-A-M-I-S.
Yeah,
it's a transanal minimally invasive surgery.
It's just a tool that we use to remove a polyp or a cancer from the inside that can't be removed with conventional colonoscope. And so the point of it would be to avoid a major operation for people that have favorable cancers and favorable precancerous tumors.
Okay, so talking surgery, I think the two best words a patient can hear are minimally invasive when they're getting ready for that. So can you walk me through what the patient will experience when they're under your care? So we talked about that it wouldn't take too long, that it might be the same day release. Walk me through, because I think that's the big hurdle that people face of whether or not they're going to deal with it versus avoid it.
Absolutely. So the experience with colon cancer surgery starts in the office beforehand. We sit down, we draw pictures, we explain everything so they know what to expect as far as how the surgery is going to go and how the recovery is going to go, along with all the risks, anticipated recovery. And a lot of times we put into motion what we call prehabilitation. We basically get the patient ready for a big surgery through exercise and nutritional supplementation. And the most important part is just education, so they go in there knowing what to expect. The actual surgical experience, we have what's called enhanced recovery, which is a multidisciplinary, team-based approach to their recovery that helps them get back to normal activity faster with less pain and overall less risk of having a complication. And so that's kind of what to expect as far as the care that I provide. The procedure itself is catered to where the cancer is at, but the most important part that I think patients are concerned with is that the amount of pain from that surgery.
Sure.
And that's usually pretty manageable because of the fact that we use the smaller incisions and we use a lot of different ways to control the pain beyond just using narcotics.
Okay. I think before I started getting to know the doctors here at Nebraska Medicine, as a patient, I think your biggest fear is that you're just going to walk in and have someone say, trust me, I got this, and not have that understanding. I have to say, from getting to know you and a handful of others, you are so willing to walk through every step and the reasons why, and to make sure that you have patient buy-in for the direction you're moving. So that leads me on to a question about our multidisciplinary approach to care. It's not just you. It's a handful of others. And can you describe kind of that approach and why it's so important to ease a person's fear and anxiety?
Absolutely. I think it's really important in cancer care for many reasons. Every cancer should be treated in a multidisciplinary approach that involves surgeons, medical oncologists, radiation oncologists, gastroenterologists, radiologists, pathologists, nurses, case managers, palliative care doctors, plastic surgeons for difficult reconstructions, and that's the approach that we take here at Nebraska Medicine. And every single patient that has a diagnosis of cancer needs to be evaluated in that multidisciplinary approach, because every cancer is unique. And one thing that is really important to mention here is that colorectal cancer is extremely unique in that it is one of the few cancers where we can still discuss the possibility of cure, even if the cancer has spread outside of the colon to the liver, to the lungs, even potentially to the peritoneal cavity. And that is why it's so important to discuss patients in a multidisciplinary setting, because you need to have all the other specialists that provide care in those other areas. Dr. Langenfeld focuses on the colon and does a lot of special surgeries with the colon, but he will see potentially 20 to 30% of patients will initially present with disease outside of their colon when they're diagnosed with colon cancer. And of all patients with colon cancer, 50 to 60% of them will be diagnosed with disease outside of their colon in another organ at some point. And that is where I can be helpful, because with my training as a liver, biliary, and pancreas surgeon, I can help decide which of those patients we could potentially remove the cancers from the liver and still potentially offer a cure to a select group of patients.
And that's important, because not every cancer, when you hear stage 4, do you have that reassurance?
And certainly for patients, we all understand that when they hear the term metastatic disease, or they hear the term stage 4, you assume all cancer are the same and stage 4 is the worst, and that's a death sentence. But what's really important, and what I really try to help patients recognize, is that every single type of cancer is completely different treatments, different prognosis, different survival, and even within all the different types of colon cancer, depending on the specific genetic mutation or how it formed and the unique circumstances of that cancer, every different colon cancer is unique. And that's why it's really important that every patient, even if you're diagnosed with stage 4 disease, for example, you should still be evaluated by a liver surgeon, because only a liver surgeon is the person that could truly decide whether or not your stage 4 disease is curable or not. And we don't want any person, any patient or any individual provider here or anywhere else to just assume you have stage 4 disease, you're not curable.
So let's continue to talk about that survivorship. For people who are currently going through it or have a loved one who is, how many people are survivors of colorectal cancer today?
Quite a few.
I think I read like around 1 million.
Yeah, that wouldn't surprise me at all. I think that we've gotten a lot better at detecting cancers earlier. We've gotten better at preventing cancer. And even when somebody has an advanced cancer, our treatment has gotten remarkably better, especially in the multidisciplinary setting, beyond the surgery itself. And so a good deal of people, celebrities and your neighbors alike, have gone through this process and are able to survive it and have an excellent quality of life and a long-term survival afterwards. And so we're lucky compared to a lot of other cancers, including number 1 cancer, number 2 cancer, like lung cancer. We have tools necessary to fix this.
And they're constantly improving.
Absolutely.
Even in the last 5 years, the survivals and the medicines that we have to use towards colon cancer are improving, and research is being published every day, and that's what the multidisciplinary setting uses. We're constantly reevaluating our practice and reevaluating the literature, and always trying to apply the newest and best proven treatments.
And speaking of research, always keep in mind that Nebraska Medicine's research arm, UNMC, is right here with us. So you talk about getting all the best and the brightest in the same room, and that's really exciting. So someone who has cancer, who survived, I feel like everybody would determine their life pre-cancer and post-cancer. So let's talk about the post-cancer survivorship. Are there long-term effects for someone who has survived colorectal cancer?
So the long-term effects are going to be unique to each patient and each situation. Most of the effects are going to be probably related to the various treatments that were received. And so that'll be a discussion that's very important to have with each of your providers as you're going through your colon cancer treatments, to discuss what will be the potential short and long-term side effects, and what will be the potential changes to my lifestyle that will be required as I live on with my cure from colorectal cancer. And so they can involve side effects from medications that are both short and long-term, and from the surgical side, from colorectal cancer surgery, oftentimes, depending on the exact cancer that's performed, there will be changes to bowel function and your lifestyle as you work with your new bowel function, and those will be specific things that you'll just want to discuss with your doctor.
Wonderful.
But the important thing that we would both mention very clearly is that colorectal cancer patients can still live a very normal and very happy life.
Sure. Is there anything that I might have missed that you want to talk about before we wrap up?
I think
did a great job.
Oh, well, thank you both.
One other thing that we had talked about before this, but that it's useful to mention, is that roughly 20% of colorectal cancer patients are hereditary in origin, so they may potentially be passed down from your great-grandmother and your grandparents and your parents to you through your genes. And it's very important that we understand which patients are potentially affected by hereditary cancer, because the treatments may be slightly different. So the risk of colon cancer, if you have a hereditary syndrome in your family, varies significantly depending on the type of syndrome, and also depending on the specific gene abnormalities that your family has discovered. So if you have a history of cancer in your family at all, and especially colon cancer, it's very important that you discuss that with your doctor, so that can be taken into consideration, especially if you're having any symptoms that are concerning for colon cancer.
Great. Well, thank you both again. I really appreciate the time you took. I appreciate you being patient as we got things up and running. Feel free to share this video, comment below. Even if you put in a question after this wraps up, we'll make sure to get back to you with an answer. To find a Nebraska Medicine clinic near you, we always encourage folks to call 402-559-5600. As you can see, Dr. Langenfeld, Dr. Reames, these are very easy to talk to doctors here with a large knowledge base, but also very relatable. You can also check out our website at nebraskamed.com. And until our next Moments of Medicine Live, I wanted to thank you for joining us again today.